Hello and salam from Dundee in Scotland. We call Dundee as City of Discovery because it has been named after a ship that you can see on the right side of this picture. This is the first ship that went to the South Pole in early 20th century, and it was taken there by Captain Scott. And this ship was called City of Discovery. Hence, Dundee is called City of Discovery, but there have been a lot of inventions that emanated from the city as well. I'm Dr. Syed Abul Kazmi. Talat Wasim asked me to choose a topic to talk about, and thank you very much, Talat, for asking me. I thought that I should talk about something ordinary and a common topic, which is known to a lot of us, but unfortunately, this is not taken very seriously in some cases and taken as a very minor or meager operation. Um, so, and this topic is a hernia. However, it is not that simple, and now it is emerging as a subspecialty. What I'll do is I'll talk about the history and advancements of hernia over centuries, its various techniques that have developed over time, and special emphasis will be on the mesh repair because that's the um, sort of technique used these days in most of the cases. I will talk about recurrence, and on top, I will talk about the post hernia pain, which can be chronic in some cases. So, this topic is from stitch to patch. It is about the evolution of the hernia and the management, and it will cover Bassini's and Schuldeis and Lichtenstein and beyond. It's often the first operation that a surgeon does in his or her career and learns it. Astley Cooper used to say that no disease treated surgically involves, from a surgeon, so broad knowledge and skills as a hernia and its many variants. And I'm sure you know this person, Professor Sayyid Farhadar, our father figure, my teacher. Uh, he used to say that if you want to learn surgery, you should learn a groin hernia operation properly. He insisted on the word properly because this involves all the skills a surgeon needs, including the cutting, sharp and blunt dissection, and defining tissue planes and suturing. What is a hernia? It's a Greek word hernios, which means budding or offshoot. In history, we can divide the hernia development in 5 years. One dates back to the Egyptian times, 1500 years BC. There was a papyrus found in the ruins, and that described the hernia, a swelling that appeared on coughing. This book was bought and then printed and is now kept in Leipzig Museum in Germany. And this is why it's called Eber's Papyrus. It was George Ebers who bought this book from Egypt. During Renaissance time, which is 18th and 19th century, the treatment began. It was always unsatisfactory, and the anatomy, however, started becoming clearer. Repair and detention was carried out in late 19th and early 20th century. Anesthesia was introduced in late 19th century. Hence, we were able to do more operations. And antisepsis was available. They used to do high ligation of sac and narrow the deep ring. But recurrence, 100% with 7% mortality. Bassini's in 1887. He was Italian. He introduced this operation by reconstruction of the posterior wall of the inguinal canal. But again, recurrence rate was quite high because it was a repair under tension. Then tension-free repair started. A tenor slide was introduced on the anterior rectus sheath, and as Professor Zafar used to say, that you make a tenor slide, and then you can go to sleep because there'll be no tension on the operation site or the repair site. Schuldeis in 1935, this man, he introduced a 4-layer repair with 34 gauge stainless steel wire needle. They don't use stainless steel wire anymore. They use proline or other stitches. And it reduced the recurrence rate to only 3%. Then we found a mesh. Francis Usher, an American. In 1957, he used Marlex mesh in dogs, then he used the same mesh in humans in 1959, and then polypropylene was found in 1961, so he used polypropylene mesh in humans, and that really started changing the things. Then we all know Lichtenstein repair. Lichtenstein is an institute in Los Angeles, in California. They produced a paper of using Marlex mesh in the 70s. 1,000 patients, no recurrence in 5 years. The man on the right is Dr. Amit, an ex-Iranian, now settled in America. He was the one running the institute, and I visited him for a week. And he taught me a lot of things about this procedure. I will mention those later on. Rini Stopper was the one who used a mesh in the pre-peritoneal space by open operation in 1975. He was a Frenchman, and his recurrence rate was 1.4% only. Then we followed further procedures. 79, Fletcher did the first laparoscopic procedure by putting a pre-peritoneal mesh. And then now we have the robotic hernia repair done in some places, but not as common yet. How do we classify these inguinal hernias? There are various ways of doing it. People make things complicated. You can see the various names with their various classifications from 1, 3, 1, 2, 3, 4, 5, and so many numbers. But obviously, to make it simple, obviously we have the direct hernia, indirect hernia, inguinal, and then we call it femoral. The European Hernia Society came up with this idea of the inguinal hernia sort of classification as L lateral, M medial, F femoral. 0 is no hernia, X is not known, and 1, 2, 3, that depends on centimeters. Obviously, hernias are different sizes, so this classification obviously may fail in some places. When you put a mesh in, this should be able to withstand the pressure of the abdomen. On lying is at 4 centimeter of water, and the mesh can withstand 650 millimeter of water. Therefore, mesh can be quite strong if put in properly. There are various types of meshes: flat meshes, Velcro meshes, like made by Covidian. You stick it in and close it like a Velcro. We have a plug and patch, inner part, the neck that comes through the defect, and this is the outside. Then you put a mesh on top of it. This is made by Ethicon. Then we have this mesh made by Bard. A plug is inserted into defect, and then a mesh on top of it. Then we can put a patch, which is a pre-peritoneal patch inserted from the front through the groin, Kugel patch. We can have proline hernia system, inner part through the defect, and then outer part. Then we have other various types of meshes that can be inserted to close the defect. We have two types of meshes: heavyweight meshes and lightweight meshes. Heavyweight meshes, they're not heavy or light just because of the gram per square meter like we use in the papers and cardboards. It is the size of the pore that matters. Larger the pore, lesser the weight of the mesh, and larger the area covered, and it can conform to the body more easily. So lightweight meshes are much better because you're putting less material in but cover the bigger area. I will touch now the Lichtenstein repair. It will probably be in more detail as well. These are a couple of slides from Dr. Hamid. He very kindly gave me these slides and allowed me to use them. This is the mesh inside. That's the cord coming from the deep ring and going through the down to the scrotum. Mesh is opened up, stitched here and stitched there. And here you can see the overlapping tails. This area, red area, means that you don't put too many sutures in this upper edge because you don't want to damage the iliohypogastric nerve. I'll mention that later on again. These are a few of my slides from one of my operations. You make a groin incision, you expose the external oblique epineurosis, you divide the epineurosis, and then you dissect and isolate the cord along with the sac. Once that is done, you identify the sac, then you dissect the sac. I tend to dissect the sac with the tip of a diathermy. That helps in hemostasis as well as dissection at the same time. It's quite a clean operation if you do that. Once the sac is isolated, you rotate it and then you transfix with an absorbable stitch like Vicryl. Once that is done, then you're putting a mesh in. Mesh is often a 15 by 10 centimeter. You slightly trim it to the size, but you want to cover a large area. The tails are overlapping. I tend to clean the area with povidone, etc. before I put the mesh in and then put new swabs around so that I don't touch the skin. That helps. We identify the pubic tubercle and we want to stay at least 1 centimeter medial to the pubic tubercle to start the first stitch because this gives a good overlap medially and it helps avoid the hernia recurrence because this is the most common site of a hernia recurrence. Once that is done, we stitch along the medial cord, along the inguinal ligament with the help of a proline and finish almost at the deep ring level. Then the overlapping tails and only one stitch here laterally, and this stitch is it should only allow one little finger, and no more and no less. If it is less than that, then there may be some edema of the area. And then a few loose stitches here along the lateral or upper border of the mesh. Make sure they are loose because you don't want to catch the iliohypogastric nerve in this area. And then we close the external oblique epineurosis with Vicryl, followed by a local anesthetic injected because this is better to inject under vision. And then skin is closed with the subcuticular absorbable stitches. It gives you a good result, clean outcome, and less pain as well. I'll touch a bit of Schuldeis repair here as well. This is Dr. Schuldeis. That's his son who is running this clinic now in Canada. That's the clinic in Toronto. I visited that, and this is Dr. Alexander who very kindly let me visit them for a week a while ago. And he even allowed me to use some of his slides for my talks. What they do is they divide the cremastatic muscle and they use the upper stump to plug the deep hole and the lower stump to plug the superficial hole. Then what they do is they always make sure that there is no protrusion of the peritoneum or a small indirect sac which one may miss. They also look for the direct area and dissect it off, and followed by that they divide the transversalis fascia After dividing the fascia, they use this to make some layers. The first line of repair is lower edge of the transversalis fascia with the back of the rectus muscle. And then it is the rectus muscle. So you can see here, it is the internal oblique that is sutured to the inguinal ligament. That is the second layer. And the third layer is again a bit of the uh, external oblique to the um, internal oblique muscle. So that's the third layer. It's all proline. And then the external oblique is sutured in front of the um, cord. And the lower end of the what you call stump of the cremaster muscle is used to plug the superficial hole. So that's four layers, three behind and one in front. Because these are multiple layers, therefore the pressure is not on one layer; it is on all the three layers. Recurrence, yes, dreaded by surgeons, and we probably concentrate a lot on it, which is very right as well. Recurrence is dependent on the patient as well as the operator, the surgeon. Patient-wise, we now know that hernia is a collagen disease, and it's the type 1 type of collagen tissue which is mature, and type 3 is immature, which is weak. Normally, the ratio between 1 and 3 is high, but in patients who have recurrence, this may well be a low. Type 1 less and type 3 more. Hence, the repair will not be very strong. Other factors that affect the hernia recurrence are smoking, high BMI, and the patients who may have aortic aneurysm, congenital dislocation of hip, Marfan syndrome, etc. In those patients, recurrence is going to be much more. And whatever you do in such cases, whatever mesh you put in, whatever best technique you can use, it may lead to higher chance of recurrence in these patients. However, it does not exclude or forgive a bad technique, bad surgery, or a bad operation. But now, after achieving so much, with so much technology, with so much new materials, our emphasis is on chronic post-hernia pain, not on recurrence. Now, what is a chronic post-hernia pain? Chronic post-hernia pain is the pain that lasts for more than 3 months following a hernia repair, and it is about 3 to 5%. You only realize if you follow the patients and they come back to you as well. For this, we need to know the nerves in the groin. We all know that there are three nerves in the groin that we encounter during a hernia repair: a genitofemoral nerve, iliohypogastric nerve, and ilioinguinal nerve. These are the nerves we need to identify, respect, and preserve. We should not include them in the stitches. And if they do get damaged during the procedure, especially in cases of recurrent hernia repairs, then we should divide the nerve and the upper end to be tied with triovicryl, and this is buried in the muscle to avoid a neuroma formation. Otherwise, it will lead to chronic pain. We must inform the patient about it. We must tell them about the numbness in the area, and we should also reassure them this may recover with the passage of time. And this is very important. This is what Dr. Hamid taught me. Post-hernia pain depends on how you handle the nerves, the inflammatory response, which will be definitely more when you put a mesh in, patient's psychomotor responses, and the patient's age. So if there is a preoperative pain patient may have post-operative pain as well. Patients under 50 There's pre-existing features of visceral or somatic pain, and in cases of recurrent hernias. What are the causes? You can damage the nerve during the operation. Nerve can get entrapped in the scar tissue or in suture. Post-operative neuroma formation. Mesh can contract and encase the nerve. Infection, recurrence, and there are many probably unknown factors as well. How do we treat them? We do physical therapy, advise the patient, do some exercise, some activities. It may improve with time. Anti-inflammatory medication. If we have pain clinics running, we can treat them with some medications as well as some advice, some local applications, even acupuncture. And surgery should be the last resort. We explore the nerve, we free up. Sometimes we may have to divide it, we may have to find a neuroma. We check for any recurrence, which may well be the cause of pain instead of a nerve. We deal with the mesh and we free up the structures in the groin. What's the outcome? Outcome wise, we say that 50 to 60% patients they get better if the operation is done properly or if the management is proper. Some patients get better with medication. 20 to 25% patients may have residual pain and it may improve with passage of time. 15 to 15% will have no change even after repeat surgery, and 2 to 3% patients may get worse pain after any procedure or intervention. So do warn the patient once you're treating such cases. Learning curve. We all learn the operation. The first one is not as good, then we slowly learn it under supervision, then independently. So the hernia learning curve. In cases of plug, open operation, Lichtenstein is 10, 20. These are the operations you must do before you can say that, well, you're now good at it. Not the expert, but good at it. Now look at this. Transabdominal, preperitoneal, and totally extraperitoneal. Here, you have to do many more procedures before you can be happy and comfortable with doing these procedures. Outcome of any operation is, and even in hernia repair, patient is the center, surgeon, a mesh, and a technique, how you do it. So that's what matters in any procedure and also in. Now some people tend to do ultrasound scans for hernias. I don't agree with that. It should only be done in cases where there is any confusion or a doubt. It should not dictate you to do an operation. It should not be your master. And it should not be a money-making tool. You should treat the patient, not the investigation or the scan. Should we operate on every hernia? Answer is no. There are some small hernias which are asymptomatic. Probably no point in operating on them. You can leave them alone. That's what we do in our NHS in some cases. Again, there's so many techniques available, there's so many procedures available. What do we do? Where do we go? We have to decide which operation to do. First one, we should do a procedure with which we are more comfortable. Therefore, we should tailor the operation to the patient and we should try not to tailor the patient to an operation. So when we do operation here in NHS, we have different types of meshes available, different types of procedures we are able to do, and then once we open, then we decide what we are going to do with the patient with this procedure. There are various types of different sizes of hernias, different types of hernias. Obviously, these small ones, large ones, and very large ones. Look at these huge ones, and a very, very large one down to the knee. So obviously, we'll have to use different procedures in different cases. European Hernia Society is the one which can provide a lot of guidance. There is an Asian Hernia Society, there is an American Hernia Society. They can provide a lot of information. If you want to, you can become a member of that. You can get some information from the website. So what's the take-home message? I would stress that attention to the details with care and respect to the tissues, like in any surgery. Keep on learning, keep on improving your techniques, as there is always a scope for improvement. Patient is the priority, so work around the patient. No unnecessary tests or investigations. And don't be the slave to the investigations. Use the surgical or your clinical acumens, which are more important. Must always explain to the patient fully preoperatively and postoperatively. So this will give you patient's confidence. Thank you very much. This is our hospital, Ninewell's Hospital, Dundee, and I'm very grateful to you for asking me, and I hope I managed to put some message across. Bye bye.